बीते दिनों गंगानगर साइकेट्री सोसाइटी की तरफ से IPS राजस्थान चैप्टर मिड टर्म CME 2023 बड़े ही धूमधाम से करवाई गई, जिसका थीम था ड्यूल डायग्नोसिस चैलेंजेस एंड सॉल्यूशंस। इस मौके दूर दूर से डॉक्टर्स पहुंचे जिन्होंने अपने विचार साझा किए। हमारी पंजाब प्लस की टीम के द्वारा यहाँ के डॉक्टर्स के साथ बातचीत की गई। आइए नजर डालते हैं IPS राजस्थान चैप्टर मिड टर्म CME 2023 की कुछ झलकियों पर।
पंजाब प्लस चैनल पे आपका स्वागत है। आज हम आए हैं IPS राजस्थान चैप्टर मिड टर्म CME है और बात कर रहे हैं क्रिएटिव जो है डॉक्टर सिडाना जी हैं और साथ में अग्रवाल साहब हैं। सर, आप लोगों का स्वागत है हमारे स्पेशल शो में।
गुड मॉर्निंग। हम गंगानगर में KLM होटल में गंगानगर साइकेट्रिक सोसाइटी की तरफ से इंडियन साइकेट्रिक सोसाइटी राजस्थान चैप्टर की मिड टर्म CME ऑर्गेनाइज कर रहे हैं, जिसका थीम है डुअल डायग्नोसिस चैलेंजेस एंड सॉल्यूशंस। जैसा कि आप सब लोग जानते हैं, पंजाब, राजस्थान और हरियाणा में नशे की लत से बहुत सारे लोग पीड़ित हैं और नशा और मानसिक स्वास्थ्य एक साथ जुड़े हुए हैं। बहुत सारे नशे के रोगी हैं जिनको मानसिक समस्याएं होती हैं, बहुत सारे मानसिक रोगी हैं जो नशे के एडिक्ट हो जाते हैं। इन दोनों की जब इकट्ठी होती है ये प्रॉब्लम, तो उनके ट्रीटमेंट में, उनके रिकवरी में बहुत प्रॉब्लम्स आती हैं। उन चीज़ों को डिस्कस करने के लिए हम गंगानगर में राजस्थान, पंजाब, हरियाणा के साइकेट्रिस्ट और नेशनल लेवल के एक्सपर्ट्स इकट्ठे होकर के आज पूरा दिन इस पर चर्चा करेंगे और देखेंगे कि क्या समस्याएं हैं जिनकी वजह से ये नशा इस एरिया में ज़्यादा है और किस वजह से ये किस तरीके से इसको ठीक करने में जो रिसर्च चल रही है उसका हमें लाभ मिल सके। इसमें करीब 100 से 150 डॉक्टर्स और PG स्टूडेंट्स हिस्सा ले रहे हैं। कुछ साइकोलॉजी के स्टूडेंट्स भी हैं और एम्स दिल्ली, एम्स बठिंडा, एम्स जोधपुर, PGI चंडीगढ़ और लुधियाना से जो एक्सपर्ट्स हैं इस फील्ड में, वो लोग यहाँ आकर के अपना डिस्कशन करेंगे। और इवनिंग में हम लोग PG स्टूडेंट्स के लिए एक क्विज़ का प्रोग्राम होगा जिसमें विनर्स को अच्छे प्राइज़ दिए जाएंगे। और इस कार्यक्रम में मेरे साथ डॉक्टर राजीव अग्रवाल और गंगानगर के सारे साइकेट्रिस्ट और राजस्थान साइकेट्रिक सोसाइटी की एग्जीक्यूटिव काउंसिल, जिसमें प्रेसिडेंट डॉक्टर जूजर अली, सेक्रेटरी डॉक्टर जितेंद्र जिनगर और हमारे CME कमेटी के चेयरपर्सन डॉक्टर RK सोलंकी बिल्कुल साथ हैं। और हम लोग मिलकर के इस कार्यक्रम को अंजाम देंगे और उम्मीद है कि इससे न केवल गंगानगर के लोगों का बल्कि राजस्थान, पंजाब, हरियाणा सभी जगह से लोगों को बेनिफिट मिलेगा। थैंक यू।
राजीव जी, बहुत एनर्जी दिखाई दे रही है सभी डॉक्टर्स में और बहुत ही खुशी दिखाई दे रही है क्योंकि तीनों जो स्टेट्स हैं वो मिल रही हैं और डॉक्टर्स का जो आपस में आदान प्रदान होगा और जिन चीज़ों के लिए हमें कोई भी डिफ़िकल्टी आती है उसके लिए सॉल्यूशंस मिलते हैं इन चीज़ों में।
हाँ सर, काफ़ी लोग दूर दूर से आए हैं लोग, क्योंकि थीम बड़ी रिलेवेंट है इस एरिया के लिए। और लोग जो हैं वो डॉक्टर शिव गौतम जयपुर से आ रहे हैं, डॉक्टर निमेश देसाई आए हैं, इबास के डायरेक्टर थे। उन लोगों को सुनने में बड़े उत्सुक हैं जिनने अपनी पूरी ज़िंदगी रिसर्च में लगा दी। और डॉक्टर AK काला लुधियाना से, उनको सुनने के लिए लोग दूर दूर से आए हैं और बड़े उत्साहित नज़र आ रहे हैं, इसमें कोई शक नहीं है। आप देखें, पंजाब, हरियाणा, राजस्थान 100+ लोग सब जगह से आए हुए हैं और ओवरनाइट जर्नी करने के बाद भी ज़्यादातर लोग आप देखो एकदम फ्रेश नज़र आ रहे हैं, एनर्जेटिक नज़र आ रहे हैं।
थैंक यू सर।
अभी हम इस कार्यक्रम को इनॉग्रेट करने के लिए गंगानगर के SP साहब पारिस देशमुख वो अभी पधारने वाले हैं। जैसा कि लोगों को पता है कि गंगानगर डिस्ट्रिक्ट में पुलिस का नशा मुक्ति के अभियान में पिछले कई सालों से बहुत ज़्यादा योगदान रहा है और पुलिस प्रशासन हमेशा से नशा मुक्ति के लिए प्रयासरत है। न केवल अवेयरनेस के लिए बल्कि ट्रीटमेंट के लिए भी पुलिस प्रशासन की तरफ से रेगुलर OPD चलती है, जिसमें डॉक्टर रविकांत गोयल और उनकी टीम कार्यरत रहती है और समय समय पर कैंप लगा करके नशा मुक्ति का अभियान चलाया जाता है। इसलिए डॉक्टर जो पारिस देशमुख हैं अभी इस कार्यक्रम में एज ए चीफ गेस्ट भाग लेने के लिए आने वाले हैं।
CME 2023. We are humbled and grateful for your presence and for your valuable time. we would like to start our program and call on the dais President Rajasthan Psychiatrist Society, respected Dr. Juzair Ali sir. Secretary Dr. Rajiv Agarwal sir. Thank you everyone for your valuable time and presence. And then we will start.
Secretary Dr. Jitendra Jingar and PMO Dr. K.S. Kamra and past President, immediate past President IMA Shri Ganganagar Dr. Subhash Rajotia, my dear friend Rajiv Agarwal, and our chief guest of the day, Superintendent Police Shri Ganganagar Paris Deshmukh sir. On behalf of the organizing committee and on behalf of the Indian Psychiatric Society Rajasthan chapter, I extend warm welcome to all the dignitaries on the dais and my esteemed teachers. Since I have been in Shri Ganganagar for the last 4 decades, there have been tremendous increase in the addiction problems in this area. We have continued to have the old addictions, the traditional sharab, afeem, ganja, charas, but on top of that we've had the newer addictions in the form of smack, heroin, and now the medical kind of addictions. And the latest, which whenever I go out to my colleagues in any meeting, either in India or abroad, the pre-gabalin is the fashion of the time of addictions these days, which is easily available in the market and is used to prescribe by doctors, but it is being misused so much that every third patient comes with saying that Priga capsule, green color capsules, 10, 20, 30 capsules in a day. And apart from those addictions, the modern addictions are also coming into this city.
गणानां त्वा गणपतिगुं हवामहे कविं कवीनामुपमश्रवस्तमं ज्येष्ठराजं ब्रह्मणां ब्रह्मणस्पत आनश्चिन्वन्नोतिभिः सीदसादनम् प्रणो देवी सरस्वती वाजेभिर्वाजिनीवती धीनामवित्रयवतु गणेशाय नमः सरस्वत्यै नमः श्रीगुरुभ्यो नमः हरि ओम् ॐ शांति शांति शांति।
Thank you, Kritika.
ज्ञानी ज्ञानी दुख हरणी जगत जननी ज्वालामुखी माता सरस्वती शारदा माता सरस्वती शारदा कीजे सुदृष्टि सेवक जाने अपना इतना वरदान दीजे कान कल और आला बुद्धि अलंकार शारदा माता सरस्वती शारदा माता सरस्वती शारदा माता सरस्वती शारदा। थैंक यू वेरी मच।
Immediate past president sir, President IPS Rajasthan chapter Dr. Jujur Ali sir, organizing chairman Dr. Roop Sidana sir, Dr. Rajiv Agrawal sir, organizing secretary, और बाहर से पधारे हुए सारे रिसोर्स फैकल्टी और पीजी स्टूडेंट्स एंड ऑल माय कलीग्स, गुड मॉर्निंग। सबसे पहले मैं श्री गंगानगर साइकेट्रिक सोसाइटी को धन्यवाद देना चाहूँगा कि उन्होंने इतने कम समय में इतने अच्छी तरीके से वेन्यू का सिलेक्शन किया, थीम का सिलेक्शन किया। बिग राउंड ऑफ अप्लॉज, जोरदार तालियां। मैं ज़्यादा समय नहीं लूँगा, मुझे बोला कि आपको 2 मिनट दी गई है, आप 2 मिनट में अपना भाषण खत्म कर दें, मैं 1 मिनट में ही कर दूँगा सर। तो आप सभी जो भी यहाँ पे उपस्थित हैं उन सबको मैं इनवाइट कर रहा हूँ, क्योंकि इस साल एनुअल कॉन्फ्रेंस हम उदयपुर में करने वाले हैं, राज साइकोन 2023। तो उसके लिए मैं आप सभी लोगों को इनवाइट कर रहा हूँ, आप वहाँ पधारें और कार्यक्रम की शोभा बढ़ाएं। डेट है 23 और 24 सितंबर। हम उसका फर्स्ट अनाउंसमेंट भी यहाँ लेके आए, तो मैं डॉक्टर मनोज शर्मा से रिक्वेस्ट करूँगा वो ऊपर आए। ये हमारे ऑर्गेनाइजिंग सेक्रेटरी हैं कॉन्फ्रेंस की, जो सितंबर में होने वाली है। तो हम ब्रोशर रिलीज करना चाहते हैं।
As a police officer, it's altogether a different world to be here, to be amongst all the psychiatrists over here. Before coming to this conference, when I was being invited by Dr. Roop and Dr. Goel, I just speaking to them what kind of conference it is and whether my presence is relevant here or not. But while explaining to me, he said that one of the topic of discussion is definitely on either treating the drug addicts or somehow related to the addiction. As a working police officer and especially as SP Ganganagar, it's a prime focus to work against the problem of drugs, the problem of addiction. As a psychiatrist, you work at a different level. As a police officer, you work at a different level. So let me share what actually we do and what kind of problem we are facing. Then I would request the August gathering that if we can deliberate on this, if this society can deliberate on this issue, and if something, even if it comes out that, okay, police works like this, then the problem, it will help in solving the problem, then we will be happy to take your suggestions and either correct our way of working or we can add to our way of working. So like Ganganagar being a border district, the kind of addiction in field, especially with respect to drug addiction, is on a very high. almost every third or fourth day we have a dead body of a young boy who is somewhere between his 18 to 28 years of age, and he allegedly his death is because of overdose of whatever addiction he is taking. The kind of drug flow in Ganganagar is, I would say there are three major routes of drug. The first one is the major, that is Pakistan, who is using drones to send these contraband items to this country. This includes not only drugs but also weapons, but also IDs. But drug forms the major part of the consignment whichever comes from Pakistan. So that is one major source. Presently, whatever cases we have seen, one good thing is when the drone comes, somebody has to pick it up. The drone drops the packet, somebody goes to near the border and picks up the packet.
सबसे पहले मैं थैंक यू करना चाहूँगा एसपी साहब का, जिन्होंने अपने बड़े व्यस्ततम कार्यक्रम में से अपना टाइम निकाला। जाना था बड़े शॉर्ट नोटिस पे, हम परसों इनके पास गए, इन्होंने देखा, कहते मेरे को जाना है कहीं। फिर जैसे प्रोग्राम खोल के पड़ा तो डी एडिक्शन का प्रोग्राम इनके दिल के काफ़ी नज़दीक है, तो इन्होंने कहा मैं ज़रूर आऊँगा। और आई थैंक यू सर, आप आए और पूरा अपना कीमती समय दिया, थैंक यू वेरी मच। मैं थैंक यू करता हूँ डॉक्टर काला जी का, डॉक्टर निमेश देसाई, डॉक्टर खंडेलवाल सर, डॉक्टर प्रमोद सर, जिन्होंने इतनी लंबी ट्रेवलिंग करके हमें, मैं कहूँगा भी हमें पढ़ने के लिए अवसर दिया और पढ़ाएंगे और हम उनकी बात को ध्यान से सुनेंगे। आई होप के सब लोग एनलाइटन होंगे आज और अपनी प्रैक्टिस में अपने पेशेंट्स के बेनिफिट के लिए जो आज सुनेंगे उसको हम यूज में लाएंगे। आई एम थैंकफुल टू माई कोलीग्स डॉक्टर अजीत सिडाना, तुषार जगावत, डॉक्टर वी.डी. मील, डॉक्टर वी.पी. मेहला, डॉक्टर अमूल्य भरत, डॉक्टर दीपक रहेजा, डॉक्टर नरेश नेबनानी फॉर दी कमिंग हेयर एंड enlighten us on their research work. I am thankful to Dr. जूझर अली जितेंद्र जीनगर, जिन्होंने मौका दिया हमको ये CME कंडक्ट कराने का, और इतनी गर्मी के बावजूद भी इन्होंने ट्रस्ट किया गंगानगर को कि आप लोग करा लोगे, लग रहा है। मैंने कहा ठीक है, थैंक यू सर, आई एम थैंकफुल टू देम। मैं धन्यवाद करता हूँ सारे डेलीगेट्स का, जो लोग यहाँ पधारे और अपना कीमती समय हमें दिया, और शाम तक ना सिर्फ कार्यक्रम को सुनेंगे बल्कि एक्टिव पार्टिसिपेट करेंगे, ऐसी मेरी उम्मीद है। मैं धन्यवाद करता हूँ IMA के इमीडिएट पास्ट प्रेसिडेंट डॉक्टर सुभाष अजरोतिया का, जो सिर्फ फ़ोन कॉल से यहाँ पधारे, डॉक्टर KS कामरा, जो यहाँ आए और हमें कुछ देर के लिए सुनने का मौका दिया।
पंजाब सिंध गुजरात मराठा द्राविड़ उत्कल बंगा विंध्य हिमाचल यमुना गंगा उच्छल जलधि तरंगा, तब शुभ नामे जागे, तब शुभ आशीष मांगे, गाए तब जय गाथा, जन गण मंगलदायक जय हे भारत भाग्य विधाता, जय हे जय हे जय हे जय 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 हे।
And I believe you know what is a meta. Meta is a the world biggest research team of Facebook based in Ireland, and I was invited to have my comments as an advisor on this particular group. And not only it was not a free kind of a contribution to Meta. It's a phone with the computer application. So we know that we begin with the desktop, then laptops, then iPads. So anything which has this computer application is, when it get integrated into the phone, it becomes a smartphone. And the first phone was in way back in 1994. And what is the smartness of the smartphone? Every phone has a unique smartness, and the smartness is just by the strength of hardware and mobile operating system. As of now, iPhone 14 Pro has the 16 billion transistor and is the world highest smartest phone, they call it. And this is the data not from Apple but from the overall technology side. And what is a smartphone addiction then? Again, since Dr. P.D. Garg was saying, sir was saying that it is not categorized under the DSM or ICD. So definition as such is also vague, and there are many definitions which are used for the same. But the most widely accepted definition is a lack of control over the use of cell phone. Means compulsive use with various consequences, psychosocial consequences, like we see in any addiction. And this is additional, fear of being without a cell phone, nomophobia. This makes it different from a chemical addiction. So when you do not have a phone along with you, that's called nomophobia, and that makes it a complete definition. Compulsive use, then psychosocial consequences, and then nomophobia. And it develops like alcohol or any other chemical addiction. Why do I say that? Because there is a tolerance to withdrawal symptoms which are reported in literature in smartphone addictions, and it works like a security blanket to overcome anxiety, stress and depression. Many people which we see who come to us for these problems or who come to us with psychological problems, if you look at it, their screen time use, smartphone use, I make it a point in my clinical practice to take this history definitely from the patients. And then you see many of them use it for the management. Whenever they're stressed, they go on a phone or anxiety or depression. And it comorbid with various psychological disorder. But controversy is still existing whether it is an independent disorder or it is just a problem with the society.
And IPS Rajasthan branch. Area of interest, social community, psychiatry and also Hindi poems. He has written Hindi poems in almost all psychiatric illness and related to de-addiction. In every day in psychiatric illness day, we are continuously reading his poems in Hindi. Thank you, sir.
Such a kind words in introducing me, and I am highly thankful to the Rajasthan chapter and the organizing committee for giving me this opportunity to talk about the women drug use, which has taken a back seat for the last so many years, and still we are not considering it, still we are not very serious about it. So the topic I had chosen is that challenges beyond diagnosis, drug use in women, because at that point of time I was thinking that dual diagnosis is a theme of this CME, and in the dual diagnosis there are so many eminent speakers will be talking about mental health issues, talking about drug abuse, and the drug abuse leading to mental health issues and mental health leading to drug abuse, and so many things are there. But when we are talking about this particular subgroup of population, subgroup of people who are using drugs, it is always there that there are so many challenges which are not written in the textbooks, which are not written in the differential diagnosis, which are not written in any of the chapters. So I thought I'll better be talking about this thing, who have not come to us for the treatment, for the services, and to avail the services. It is that population to whom we have not been able to reach. We have not been able to make them comfortable so much that they will easily come to us for services, because so many centers we have so many treatment options we have, so many things are there in our basket, but still we are not able to provide them the services. This is the hidden population. This is not one way that this is hidden. It is from both the sides, it is hidden. And the irony of the situation is that the policy makers, the governments, they are still not very serious about the issue. They are not still thinking about the issue. They are not thinking about the depth of the problem that we are facing right now and will be facing in the coming few months or few years. 19.5 million females are there, ages 18 or older, who have used illicit drug in the past 1 year. This is a huge figure. This is 2019 figure. And if we see the Indian studies starting right from 2000 and till this time, every study has shown that all the number of drug users in this subgroup of drug users, there are 2 to 5% of the females in every group, starting from alcohol to opiates to polysubstance abuse. There have always been the women in the range of 2 to 5%. This is again a huge number, and you can see that this is not the kind of new addicts we are having, not the new addicts we are seeing. It's the hidden population from our side also. That people have always been there, this group has always been there, but we have not been able to approach them. We have not been able to make them comfortable.
The postgraduate sitting here know about the exhibition of some photographs which Dr. Kala curated with Dr. Anuksari, and which went from place to place. And then he wrote also about the impact of, as I was saying, about the impact of partition in 1947 on people with mental illness. Because I don't want into the history, I would urge all of you to read his novel and also his book about this aspect. Third thing which Dr. Kala should be known about is that it's a very popular society, parallel to the Indian Psychiatric Society, is the Indian Association of Private Psychiatry. And he was the person who gave the idea first of all. I think he wrote an article first of all in Indian Psychiatric Society only about the need for such kind of association, because the private psychiatry was taking its root in late 1980s and 90s, and there was no forum for them. The Indian Psychiatric Society was all about academics, institutions, professors giving lectures, but the problems being faced by private psychiatrists, and especially after the Mental Health Act of 1987, right? The problems increased many folds, and the need was felt to have some forum where private psychiatrists could also discuss the problems and carry it to the government for some rectification. And then Dr. Kala has been very active in the field of drug dependence and de-addiction from the time when none of the medical colleges in Punjab were paying any attention to this particular aspect of crisis. And we all know about his work in Ludhiana in his center, and about the various articles which he wrote. And then came this book, which is about the various aspects of drug dependence and its management.
The Mughal era and the India era before the partition and also previous eras. Apart from the history of addictions, Professor Kaula also describes the science of addictions, the nature versus nurture debate, which about the origins of addictions have been handled in this book very carefully. As highlight of most of what you know about addiction is wrong is the way the data has been treated. Statistics about the number of people using drugs and those affected by addictions have not just been quoted but explained in an easy to understand manner. And also we all know the situation in Punjab and India, especially when the elections are coming, the statistics are jumbled up. The book draws the reader's attention towards the criticality of credible data on substance use and skillfully demonstrates how to derive meaning from that data, addictions, and how we should continue it. And I would like to ask Dr. Kala a few questions. The first question is that comes to mind, as you have been fiction writer. So what were the thoughts behind writing this book and what provoked you to write this book?
Thank you, Arinda. What provoked me to write the book? Actually, that's not difficult at all. All of you, including me, we have been hearing this course of say no to drugs, and very sincere and intense police officer today morning was lamenting the fact that the drugs keep coming. And you catch 2 people and then 2 others or maybe 3 others join in, and that he correctly surmised is because the demand is there. And he wants you to know when will and how will that demand extinguish. Actually, I have a bad news for the gentleman. The demand is not going to go anywhere, anytime. Why? Because addictions have been there since time immemorial. Now, human beings and some animals also have a desire to periodically feel different. And this is the 4th drive after Ronald Siegel calls it the 4th drive after food, sex and sleep. So innate drives don't go anywhere. Innate drives have to be managed.
You will talk. I said you allowed the topic and I will talk. He said the theme is dual diagnosis. So I thought why not talk on dual diagnosis from evolution of concept to current practice. Chairpersons, my dear friend Sudhir and my dear student user, and I am so happy that both of you are chairing this session. This particular session is not meant for very senior people sitting here because they have themselves been witness to the evolution of concept of dual diagnosis. It is meant primarily for postgraduates who have been listening. So, I have to make 2 changes. So, we start from classification. First 3 slides I will talk on the basic concepts. What constitutes a good classification of psychiatric disorders? And the main themes which are guiding classification are reliability of the classification, which may be from integrated reliability or reliability from time to time change. Validity, whether we are really diagnosing that. Utility of the diagnosis, not in a particular geographical area, but utility across the culture and across countries. Each to use, how easily we can use the diagnostic classification system. Applicability across settings and cultures, and which meets the needs of the various users. For example, clinicians, researchers, users, mental health services.
पंजाब, बिकॉज पंजाब के बारे में काफ़ी बातें कही है डॉक्टर काला के कॉन्वर्सेशन में, उससे पहले डॉक्टर संदीप बोला ने बात की विमेंस इश्यूज की, एंड डॉक्टर शिव गौतम, आई थिंक ये स्टेप्ड आउट, बट डॉक्टर शिव गौतम सेड दैट दो ट्रीटमेंट प्रोफेशनल्स अलग हैं, प्लीज बी श्योर नहीं है. द ट्रीटमेंट प्रोफेशनल्स फॉर बोथ आर मेंटल हेल्थ प्रोफेशनल्स एंड साइकियाट्रिस्ट्स. Only the administrative ministry's different department of social welfare gives you the money and administers the NGOs for drug abuse treatment. Like I have repeatedly said on too many fora, please don't confuse clinical scientific aspects, one, or even regulatory technical aspects with financial or administrative ministry. Substance abuse by itself and mental problems both are essentially the domain of psychiatrists and mental health professionals. Because NGOs are funded by welfare department, very often many of our psychiatrists trying to kind of keep away from the NGOs dealing with substance abuse, and we are harming not only our own interest but also the patient's interest. पंजाब का मैं इसे रिफर कर रहा हूँ कि like I have been saying to a few people last night and this morning, and I hope जुजेर जी है ना, जुजेर कहाँ गए? जुजेर सर, जुजेर आप और आप सेक्रेटरी तो हमारे हैं, कहाँ गए सोसाइटी? हाँ नहीं, वहाँ गए. I really have a very strong recommendation to make to Rajasthan Psychiatric Society और बाकी seniors जो help कर दें. What Punjab has done is a terrible error. Punjab all drug abuse treatment centers are regulated under the NDPS Act. NDPS Act is not a health legislation. It's an enforcement law. It is for curtailing what the SP was referring to as drug supply curtailment. And in Delhi, at some point of time, 3 or 4 years, 5 years ago, it was about to be done कि पंजाब मॉडल फॉलो करके सारे ड्रग अब्यूज ट्रीटमेंट सेंटर्स जो 150-200 उस वक्त थे दिल्ली स्टेट में, उनको एनडीपीएस के रेगुलेट कर दिया जाता. I have single-handedly fought with the High Court, with the LG, with the state government and everyone and the NGOs to make sure that Delhi now has drug abuse treatment centers under the SMHA, under MHA 2017. So what I am very strongly urging the Rajasthan colleagues is to, whenever you get a chance, make sure that you can argue and do advocacy with the state government that drug abuse treatment centers, even if they are, and I repeatedly will keep saying this, even if they are funded by welfare department, even if they are run by NGOs and recovering addicts, the technical regulation has to be under Mental Health Act. And Delhi has already done that. Few other states in South have done that. Karnataka, Tamil Nadu, Kerala. So you have enough examples, but there are examples from Delhi. So at least about that, please don't follow the Punjab model. Because if you follow the Punjab model, then what Dr. Shivatham was saying becomes unfortunately more true. Mental health treatment will be under psychiatrists and mental health teams under the MHA. Drug abuse treatment will go under either the welfare department or the NDPS. And like is happening in Punjab, it's the police that regulate the technical treatment of drug abuse.
Dr. Desai sir has laid the foundation for most of the things that are worthy of deliberating. But just taking it forward from there, whether the chicken came first or the chicken egg came first, I think if you deliberate, the whole think revolves around to begin with, primary and secondary. So let me elaborate. Depressive symptoms, as said, immediately during the withdrawals of alcohol. Psychotic symptoms that emanate pursuant to cannabis use. And we see in our clinical practice that the presentation is very florid, there is a huge lability, the symptoms peak very fast, and it's almost like what the ICD describes or originally described in the criteria of what was called as the ATP, the acute and transient psychosis. The settling down also is, I remember Professor Agnihotri used to say, like doodh ka ubal. It goes up very fast, and sometimes the patient begins to settle on day 3 or day 4. I mean, and that obviously has been listed as a good prognostic factor in terms of the symptoms peaking very fast. Psychiatric primary psychiatric illness which is severe with substance abuse which is not so severe. Second group, substance use which is very severe and the psychiatric symptoms or psychiatric morbidity is not very severe. The third group where the psychiatric symptom and substance dependence both are very severe. So this not dual but triple diagnosis, as was mentioning, which actually get written off. Nobody wants to really sign them off, but they are the ones who really need consideration and treatment from us, and to really, coming back to policy as I was mentioning, to get it under the ambit of state mental health authorities where we will possibly be encouraged. See, I think the ICD or DSM not really, the current versions not talking about dual diagnosis so much. Number one, like sir said, they conveniently encourage multiple diagnoses, you know. Second, I really want to think if that has to do with also being empathetic in terms of if the symptom presentation is worthy of ये नशेड़ी भी है और ये दिमागी बीमार भी है. So एक स्टिग्मा नहीं, अब 2 स्टिग्मा हो गए. तो अब आप किस चीज़ को राइट ऑफ करना चाहते हैं? You want to write off the dependence issue? So in terms of, I think, treatment, and if we see and relate that chronology to the treatment modalities that have evolved over the years, from sequential treatment to parallel treatment to the currently propagated integrated treatment. And like sir said, in the integrated treatment model, there will have to be a leader, and I think by all options that leader should be worthy of a mental health practitioner and ideally a psychiatrist. If there is a psychiatric social worker, and all of them have due role to play, but I think also that empathy would entail for psychiatrists. I mean, I remember some interns posted at a particular center, and they described that, you know, and they're very critical and they watch us more than we watch ourselves. Is it this particular doctor smoking cigarette non-stop and telling them, yaar sharab mat piya, yaar sharab. That's not going to be enough in terms of the advantages in the armamentarium that we have vis-a-vis the anti-craving medication today. But I don't really think the holistic flavor of the, like Dr. Gautam was mentioning, the motivational enhancement therapy, that is a very integral part of the treatment and is depictive of an unconditionality that you bestow to the patient. The cognitive remodulation, the community support, the self-help groups, the 12-step program, and please, mind you me, these are programs that have survived for decades. So I'm sure there is a certain advantage, and there are some beautiful papers which have gone on to see the psychological paradigm and parameters in the 12-step program, with each step, you know, graduating to the next step.
substance-induced mood disorder, substance-induced psychosis, substance-induced anxiety disorder in a particular rubric. So no direct name of dual diagnosis, but it is when this direction is very clear, it has started because of substance. So the second, when the person is presenting with both, be it is depression and with alcohol, because I'll be covering in the second part alcohol, then yes, one, as mentioned by Desai sir, the observation assessment is very important. But yes, over the time, tentatively after a week and 2 weeks, these symptoms are reasonably less in larger number of people. But yes, if the symptoms are very severe, in a way suicidal ideas, attempts, plans, or other way the florid psychotic symptom, then yes, one has to treat those psychological symptoms as well along with substance. But if those symptoms are lesser in intensity, then observation and some behavioral measures will help along with the main substance related treatment. And that's why the treatment has been suggested into one of the model is 4-quadrant model, which maybe if the person is having lower intensity mental with illness which is now stable, as well as the substance part is also stable, they can be treated at any facility. But yes, if the mental health issues are more into the presentation and substance is stable, for example, somebody is now sober in remission or on OST, then one should be taken care by the mental health facilities. But if the substance is now more difficult and the psychological problems are settled, somebody is on antidepressant, no symptoms, then should be taken care at the de-addiction facilities. But if both the things are there, the severe mental illness symptoms as well as the addiction substance which is currently regular and causing problem, then yes, the answer is integrated treatment, as since morning we are discussing.
The later development of the psychosis. For example, if a person who is genetically vulnerable to develop the schizophrenia and if this person was not exposed to the cannabis, and he may develop at the age of the 25 years. But if person was exposed to at the period of the adolescence, the time may become decreased, or may person may develop at the earlier age of around the 20 or 22. That indicates that there is a definitely association between the use of the cannabis and the development of the psychotic disorder.
This is like, everyone knows that opioid use disorder is the world's most problematic illegal substance. Approximately 36.3 million opioid users are there globally in 2019 as per the World Health Report 2021. This has increased in the recent report which has been published in 2022. The magnitude of substance use disorder in India, which is conducted by the NDTT's aims to the DALYs, which is basically disability adjusted life years and also drug related deaths. Now coming to the management which we use for opioid use disorders, they are broadly divided into agonist management and also the antagonist management. The antagonist management is the abstinent model, it is followed. The agonist model is harm reduction. In the abstinent model, initially the withdrawal symptoms are managed symptomatically, which is either using the opioid substitution like methadone, buprenorphine or other medications, and which is followed by when they are free of opioid, then you start them on opioid antagonist, which is an naltrexone. The symptomatic management, it's usually for 2 to 3 weeks depending on the withdrawal symptoms, and when you have urine screen negative, then you start them on naltrexone after having an naloxone challenge test. In the harm reduction strategy, the main strategy is to continue the patient on opioid substitution therapy, which is usually to decrease the high-risk behaviors and the consequences because of the high-risk behaviors or continuous use of the opioids. And non-pharmacological management has to be done throughout the course of the management and even after termination of the opioid substitution therapy. The non-pharmacological management, initially will be the motivation enhancement or making aware of what is the why we are starting them on opioid substitution therapy and what they have to do, do's and don'ts when they are on medications. These and all, and in the later part basically the termination phase we prepare the client or the subject or the patient to terminate the opioid substitution gradually over a period of 2 to 3 months, and even after they have been stopped, usually advised to continue non-pharmacological management to address other issues even for minimum of 1 to 3 months or up to 6 months.
Patients, Dr. Rajiv and me have given alcohol in the ICU also. Because there is no other way to treat this patient. Just bring alcohol and give the patient alcohol to make him calm, make him calm immediately. Right. Third thing is, I would like to ask all psychiatrists fraternity through Dr. Shah that how much you are having experience for the direction of smoking. If you have the experience of direction of smoking, are you using drug treatment or are you using counselings? Are you using intermittent withdrawal? And are you using bupropion? How much frequently you are using bupropion? Or how much frequently you are using penicillin drug? And in my experience, to leave smoking is more difficult than to leave alcohol. Because for alcohol we have few drugs which can take over. But to leave smoking, this is very important from COPD point of view. Otherwise I never overstress any restrictions on the patient who are more than 60-70 years of age. But in COPD you will have to stop smoking. You will have to quit smoking to arrest the disease process which is going inside. So personally, I will tell you my experience later on. But first I would like to ask your experience about the addiction of the smoking. So these are my few of the questions and I wish you to answer.
Thank you for putting forward these very practical and relevant questions, sir. I would like to answer them in the reverse order. So the last question first, about smoking. So if we see any substance used in addictive manner, has two major components. One is pharmacological treatment and another is the psychosocial treatment. So pharmacological treatment for smoking is basically a treatment for nicotine dependence. The medications in terms of their effectiveness and their nicotine replacement therapy, where do they stand? There was a very interesting review, a Cochrane review in 2013 by Kyle et al., where they did a meta-analysis also. Varenicline as a single agent was found to be the most effective, closely followed by combination nicotine replacement therapy. That is a patch which gives a regular dose of nicotine to the patient and topped up with SOS, oral or spray or some lozenge kind of a nicotine. These two were the most effective. They were followed as a single agent closely distantly by bupropion and nicotine replacement therapy. Bupropion and nicotine replacement therapy also have a little difference amongst themselves, but these two are inferior in terms of evidence to combination NRT and varenicline. Now the practical problem in current scenario is that varenicline is not available. The original molecule by Pfizer has been off shelves since around 1.5 years. So varenicline is out, so best option as of now is combination nicotine replacement therapy. Although one company has come up with a version of varenicline, but that is to be seen how it goes. Second question of yours was regarding ICU, a person of alcohol dependence, delirium, maybe delirium tremens, and a conundrum, what to do. The last then the first person, I'll come to that. So a common problem is that somewhere we believe that lorazepam is considered safer in that sense of respiratory depression as compared to diazepam. So there the doses to load can go up to very high levels. Sometimes even up to 400 mg of chlordiazepoxide. Of course, you don't give it at the one go. You load him by repeated dosings every half an hour, sometimes even on a lesser duration if the condition demands. So the loading doses are very high, which are not achieved in a routine medical treatment setting. So that could be one of the reasons that patients commonly go into delirium and progress to delirium tremens. So going into delirium is not a very difficult condition to manage, but going into delirium tremens has a high mortality rate also, and there the problem starts that sometimes the patient's attendants start saying we brought him in a good condition, and the second day you have brought him to this condition that he is not even recognizing us, and those kind of problems. So one solution to that can be having an idea of risk factors for going into delirium. These risk factors are generally a history of malnutrition, comorbid medical conditions, previous history of complicated alcohol withdrawal. Sometimes the patient, when they come, they are not in severe withdrawal. They themselves describe कि जब मैं छोड़ने की कोशिश करता हूँ तो मेरे को नींद गायब हो जाती है, आवाज़ें सुनाई देने लगती थी. History of alcohol withdrawal seizure in past. Tachycardia. If the patient presents to you with a pulse rate of more than 120 beats per minute, some studies even say that. So if there are risk factors, we should go for loading regimes of long-acting benzodiazepines if not ruled out. With lorazepam also loading is possible. Sometimes even infusions of lorazepam can be used, although that is not my clinical experience using lorazepam infusion. So that is about the second question you asked, that ICU delirium, especially delirium tremens, is preventable to a large extent.
What can happen with alcohol in neurology, or what can other substance abuse cause in the problems? So these patients can have orthostatic hypotension, as I said, ischemic strokes, hemorrhagic strokes, all sorts of stroke. I can understand it's the want of time, and I think we have taken this session probably far too long, and let's end it here. Thank you.
I would like to say last one word, that in my experience, if we are giving nicotine in chewing gum form or something form, we are just sparing lungs. Rest of the harms we are giving to the patient also. So what do I suggest to my patients? Okay, I say postpone your desire. If patient is having 1 hourly smoking, I say postpone it for 15 minutes. Ultimately he come to OD or TDS dose. The most vulnerable dose is in the morning while he is going to defecate. He needs the smoke, number one. Number two, few of the patients who are reaching to TDS level just in the morning to defecate, number one, and after meal, after lunch and after dinner. Ultimately they come to that place only. And third thing, so many of the psychiatrists, they are available over here. Please use propranolol to the minimum level.
And why?
Because this is a respiratory toxic drug.
We use propranolol fully well.
Sir,
don't scare us.
What I'm saying.
Don't scare us.
Yes, sir.
I think it's very good. क्या कर रहे हो? ऐसे ही डरा रहे हो बच्चों को.
Sir, at least ask the history of asthma.
नहीं sir, time.
Ask the history of asthma.
नहीं बेटा क्या? Of course.
Ask the history of asthma. That's what I'm saying. Because patient is coming to us in status asthmaticus. I'm telling you, or acute severe asthma.
उसमें तो देंगे नहीं ना.
Precipitated by beta blockers.